Good afternoon. My name is Susan Lynn Osterly, and I'm the VBID Center Program Manager. My pleasure to welcome you to the 2023 VBID Summit, Accelerating Health Equity. First, I'd like to thank the incredibly talented and dedicated members of the VBID Center staff for their support in making this event possible. Jordan Clark, Rachel Sismaric, and Chantel Martin. Of course, we'd like the summit to be as interactive as possible, so please send your questions and comments via the Q&A tab on the Zoom control panel as shown here. Now, I'm very pleased to introduce the director of the VBID Center, Dr. Mark Fendrick, to start the summit.
Thank you, Susan Lynn, and that VBID Center staff. I'm so appreciative of all your hard work and dedication. On behalf of the U of M VBID Center, we all welcome you to the 2023 Summit, Accelerating Equity. It has been quite a journey since Mike Chernew and I conceptualized what has been called value-based insurance design. Next slide, please. As I reflect on the 20 plus years that we were working on this, I go back to Kang's Korean restaurant here in Ann Arbor, where Mike and I first supposedly chatted about what ultimately came VBID. And here's a picture of a much younger version of the two of us from our first summit on a very snowy day in December of 2005. Next slide, please. There are many of you from around the country are being exposed to the Center for Value-Based Insurance Design for the first time. And it's really important to point out that none of this effort that we've been putting in the center since 2005 would be able to happen if it weren't for our generous sponsors. And the sponsors of the VBID Center and the VBID Summit for 2023 are shown here. We are particularly pleased to see a broad diversity of supporters, from health sciences companies to health plans to health technology companies to consultants to consumer advocacy groups, as well as provider advocacy groups. And I think that really brings to bear the multi-stakeholder approach that the Center for Value-Based Insurance Design has actually brought. Next slide, please. So, I'm missing, okay. If you could go back, Jordan, there were a couple slides that I wanted to see. I think I'll just say very briefly that many of you have heard me talk before. The inspiration of value-based insurance design comes from my mother, who said in the year 2000, I can't believe you and Mike had to spend $1 million to show that if you make people pay more for something, they'll buy less of it. And this led to us creating the idea that patients should have easy access and affordability to those services that make individuals and populations healthy, with particular attention to those that enhance equity, and thus the focus of our summit today. So the three priorities of us moving forward, based on a number of initiatives that we have ongoing that we'll share in the chat, basically focus on three things. First is improving access and affordability to high-value services through the reduction in cost sharing and other financial barriers to those services, whether it be reductions in co-payments or co-insurance, or our focus on pre-deductible coverage. And the timing is quite good that some of you might have read in the VBID Center newsletter that just Monday, Senators Thune and Harper introduced a bipartisan bill to the U.S. Senate to expand pre-deductible coverage for chronic disease services that prevent complications of many chronic diseases that are impacted more by low-income people, communities of color, and those with multiple chronic conditions. We've also spent a fair bit of time identifying those services that at best don't make Americans healthier and often cause harm. So we focus on the identification and reduction in low-value services, so we can identify funding to allow more generous coverage of those high-value services. And the last point is the alignment of what's going on in the alternative payer model space as we move away from fee-for-service to that of value-based or outcomes-based contracts. And that as we incent our clinician colleagues to provide more of the good stuff and less of the bad stuff, we'd like to see benefit designs aligned so that it's easy for clinicians and patients to get those services that make them healthier and make it harder for those that don't. Next slide, please. So it is my great pleasure, as we have for every VBID Summit for the exception, for me to turn over the virtual microphone to my very close friend and colleague, Cliff Goodman, who will lead us through an excellent day of sessions as we talk about improving health, enhancing equity, and spending our healthcare dollars more efficiently. Cliff, it's all yours.
Thank you very much, Mark. Glad to be on. And thanks everyone for joining today. You're in the right place, I will tell you that. And it's very gratifying to hear Mark give the kind of the short version of the evolution of the VBID Center. And it makes perfect sense that we're landing here today on advancing health equity. The principles of health equity are in many ways embedded in the history and the mission of the VBID Center. And those of you that have been kind enough to join us in previous summits have seen that evolution. But this issue today is the one that we just got to get on. And I think that we put together a fine program with the leadership of the VBID Center, 4 panels to get into this issue in a concrete way. Can we go to the next slide, please? So here's our agenda for today. And you'll see that we've got 4 main sessions with a break sandwiched in between. The first session is our keynote panel, and we're going to look at the concept of accelerating health equity. It's upon us. It should have been upon us earlier. And from 3 distinct perspectives, you're going to hear from leaders why we've got to put this pedal to the metal. The second session is on equity implications in health plan benefit design. So sure, we're all kind of for health equity, but what about health plan benefit design? Health plans aren't necessarily designed, at least originally, to think through health equity, especially as we consider it today. So that gets into some real concrete issues. After our 15-minute break, we're going to go to our third session, which gets into specifically advancing pharmacoequity and enhancing access to essential medications. To pick up today's paper, get online, whatever, you're going to see all kinds of news about pharmacoequity and enhancing access. Pick your favorite condition. How about diabetes? But there are others as well. Session 4 is going to take a look at incorporating equity into the determination of value. VBID is about value, of course, but of course, in parallel, there's been a lot of work done in things like cost utility analyses and deciding what value is. What are the components and criteria and parameters of value? Well, do those fit? Is there a place for health equity in the evolving notion of value throughout healthcare? So that is a great agenda. Stick with us. And by the way, after toward the end of each panel session, we will have an opportunity for Q&A from you. And you know that there's a Q&A place to enter those. And let's go now to our first panel. I don't mind starting a minute or 2 early here. All right. This is our first panel on accelerating equity, our keynote. You see that we're going to be represented by the insurance industry, by the, I'll say the pharmacy and payer industry, and by the White House. Here's what we're going to do. I'm going to ask each of our 3 panels to introduce themselves with basically remind us about your name, title, and affiliation, and then tell us in a sentence or 2 how it is they find themselves on a panel of this title. After those quick 3 intros, we're going to circle back, and I'm going to ask each one in order, and it's going to be, it'll be Kristen, Grace, and Jonay, to basically convey to us a 3-part story in a confined period of time. The 3-part story is basically this. What prompted, what triggered your organization to start taking a very serious look at accelerating equity? What made you kind of turn your heads in that direction and say, we got to do something? And then the second part of the story is, well, what are you doing? Any programs, initiatives, research, data collection, whatever it is, what have you gone about doing to pursue accelerating equity? And the third one is, has it had any impact to date? Any results, any findings, any observations? What have you seen thus far? And maybe a quick look ahead. And then we'll go to your Q&A. So with that, Kristen, could you set a good tone for getting us started with your self-intro?
Great. Hi, everybody. I'm Kristen Link-Young. I am the Deputy Assistant to the President for Health and Veterans Affairs here at the White House, where I lead the health policy team in the Domestic Policy Council. My role is very much to drive the President's priorities around equity and improvement in health and well-being across the entire population, across the U.S. government. And I think that's part of the reason I'm here today.
That is. Thank you very much, Kristen. Let's go next to Grace.
Hi, everyone. I'm Grace Arnold. I'm the Commissioner of the Minnesota Department of Commerce, which is the insurance regulator in Minnesota. I'm also the co-chair of the Special Committee on Race and Insurance at the National Association of Insurance Commissioners. So I wear two hats in speaking here today and have two different journeys that are in some ways related, but in some ways different. The NAIC was so I'll talk a little bit about that in the second part, but I'm wearing two hats, but I'm really excited to be here wearing both of them.
You wear them well. Thank you very much, Grace. Let's go next to Jonay, please.
Yes, good afternoon, everyone. I'm Dr. Jonay Khaldun. I have the honor of serving as the inaugural Vice President and Chief Health Equity Officer for CVS Health. So that means that I get to work across all lines of the CVS Health business, the over 100 million people that we serve every day, and really help the company think about how do we do that in a way that leaves no one behind. I also have a background leading public health departments. I'm a practicing ER doctor. And so I think that's why I'm on the panel today. And also happy International Women's Day.
Thank you for that reminder, Jenny. Thanks. And by the way, you actually started to answer one of the first parts of the story in that you shared with us that this position was just created. And you're the first to take it on. So that we're already seeing some response there. Well, let's go back to Kristen. And I know, Kristen, there's a lot that you could relate to us, but from the standpoint of where you sit at the White House, what kind of launched the interest in this? Where did you take it? And have you seen any impact? Kristen?
Great, sure. And glad to be here with everybody today. So President Biden came into office with a deep and deeply rooted commitment to driving equity across the federal government. On his very first day in office, he signed an executive order charging the entire federal government, his White House staff, as well as agencies across DC and across the country, with using the policy levers that they have available to them to drive equity in all of our decision making. And since launching that executive order, he's followed on with additional formal executive orders, using his power as the president, as well as really a whole of government strategy that is committed to driving equity in the decisions that the federal government makes. My work here at the Domestic Policy Council is to really work across the federal government to implement the president's priorities on equity and everything else. And so that means convening federal agencies to work together on policy problems and challenges that involve multiple different agencies working in partnership with each other, and working individually with specific agencies to drive as much policy change as quickly and effectively as possible across the federal government. And so when it comes to accelerating equity, I want to highlight a couple of the problems that we have taken on, and some of the accomplishments in a number of different spaces. There is so much I could cover here, but there are a few areas that I want to highlight for the group. First, our work to promote insurance coverage and drive increased enrollment in health insurance programs. Today, I am incredibly proud to report that 16 million people have coverage through the Affordable Care Act, an all-time high, and Medicaid enrollment is also at a record high, accomplishments that have together driven the uninsured rate to the lowest point in history at just about 8%. And those numbers are incredible. They are a source of a tremendous pride for our team at the White House and for the president, a reflection of a really incredible effort across the federal government and with our partners in the states and in the private sector to drive enrollment. But they also come at a really incredible time. As everyone knows, the U.S. economy has come through a significant economic shock and a time of challenge, and that usually results in major coverage losses across the country, but especially for people of color and underserved communities. And instead, this time around, in the period from 2020 through the present, thanks to smart policy response, we have moved the uninsured rate in the other direction and achieved, these record highs in the number of Americans that have health insurance coverage. Some of that began under the previous administration, and it was continued in this administration with two pieces of legislation that were signed by the president, the American Rescue Plan and then the Inflation Reduction Act, to dramatically lower health insurance premiums for people who don't get coverage through work. So thanks to those interventions, ACA premiums are $800 lower per person per year than they otherwise would have been on average. And that has really contributed to this incredible growth in enrollment, 3.6 million new consumers this year alone, and really incredible growth in the number of people who have the security and peace of mind that comes with affordable health insurance. One of the great privileges of working in the White House is getting to hear from people all over the country about what that additional support and the ability to get health insurance means to them. And the president talks a lot about what it means to have just a little bit more breathing room from making health coverage more affordable. We are obviously entering a period where state Medicaid agencies will begin making redeterminations of coverage for the first time in a number of years. And we are committed to a whole of government approach to make that as smooth as possible and ensure that as many Americans retain access to health insurance as we go through this period of transition. The second body of work I want to talk about is our work to lower prescription drugs. Decades of research show that underserved communities face the most difficult challenges in affording prescription drugs and have for years. And the president was proud to sign landmark legislation to lower the cost of prescription drugs in Medicare last summer. A number of key components of this legislation. Medicare, for the first time, has the power to negotiate prices for the prescription drugs that it buys for our seniors. There is a new requirement that if drug companies increase their prices faster than inflation, they're going to owe a rebate back to Medicare to help moderate price increases. And we placed a $2,000 cap on costs that Medicare beneficiaries will face at the pharmacy. So starting in just a couple of years, no senior will pay more than $2,000 in Medicare Part B cost sharing across the course of the year. A particular interest, I think, to this group is the components of that bill that lower insulin costs for people in Medicare. So we now have a $35 cap on insulin, on a month's supply of insulin for everyone in Medicare, a critical protection that makes insulin more affordable. The president has called for that same protection to apply in the private market as well, because everyone deserves access to affordable insulin. I also want to highlight some of the additional work we are doing on prescription drugs beyond the Inflation Reduction Act that the president signed last year. And so the president announced earlier this week that his budget will call on Congress to cap cost sharing at $2 for kind of low-cost, high-value generic drugs that are used as maintenance medications for people with chronic conditions. And that call for congressional action builds on a model that the CMS Innovation Center has announced they will be pursuing to attempt to establish, a real standard of $2 high-value generic drugs in the Medicare Part D program, and something that we are really excited to be working on. I want to move quickly through just a couple of additional topics. First, our work around the social determinants of health. We all know that no health problem can be solved by the healthcare system alone, and we have decades of work demonstrating that investments in the drivers of health, housing, food, stability, education, transportation, those really matter to well-being. And so we have been working to really institutionalize that commitment and support innovations in the social determinants of health at scale. We know that Medicaid plays a critical role in this story. So we have been working hard on Medicaid waiver programs and demonstrations and new investments that support the social determinants of health, and empowering states to work with their managed care organizations to really embed an investment in the drivers of health into the way state Medicaid managed care organizations operate and serve their beneficiaries. I want to highlight some work earlier this year, I guess last year now, to hold a conference here at the White House on hunger, nutrition, and health. 50 years ago, President Johnson hosted a conference at the White House on hunger, which was the jumping off point for what ultimately became the modern SNAP and WIC programs that provide a tremendous buffer against food insecurity for low-income communities. And last year, for the first time since that initial conference, we brought stakeholders together here at the White House to address hunger and nutrition and health, and think about what the call to action for this generation would look like. We released a detailed strategy across 5 pillars addressing hunger and nutrition: improving food access and affordability, integrating nutrition and health and through programs like medically tailored meals and food as medicine interventions, empowering all consumers to make and to have access to healthy choices, supporting physical activity for everybody, and enhancing nutrition and food security research. And we're continuing to work with stakeholders and across the federal government on driving that strategy.
In just about less than a minute.
And lastly, I just want to say, just want to close with just a few words on tobacco. Earlier in this administration, we proposed a ban on menthol cigarettes and flavored cigars, products that are designed to appeal to youth, and where the president has proposed taking action in this market. And we're also taking on e-cigarettes and getting fruit and candy flavored electronic cigarettes and related products off the market, which again we view as critical to advancing health equity and preventing the harms that come from tobacco use. So with there, I will come to an end and pass the baton to Grace.
Well, thanks very much, Chris. You covered a lot of territory. Teeing you up for later, we already have a question about the number of uninsured and the percentage of Americans who remain uninsured. So we'll hit on that later. But you really hit on some important points about how uninsured has actually gone down, how many people are in ACA, prescription drug costs, pressure down on insulin and others. There's been an industry response. You talked about cost sharing provisions, social determinants of health, food insecurity, and tobacco. You covered a lot of ground, and in their own ways, every one of those has, and also premium coverage, holding the line on those. We may have to rewrite Econ 101 for how the economy has responded under these conditions, but in any case, you really hit probably 8 or 10 ways in which you all at the White House are pursuing this important issue. So thank you. All right, let us move next to Grace. Grace, what's your 3-part story? We're really wanting to hear it, and this is another important perspective.
Thanks, Cliff. I'm really excited to be here. So I'll talk from both of the hats that I'm wearing here. So in Minnesota, equity and inclusion have been top priorities for the Walz-Flanagan administration since they took office in 2019. So the vision for Minnesota under the Walz-Flanagan administration is that Minnesota is the best state in the country for children to grow up in. And then the vision goes on to be very specific to say that's people of all races, ethnicities, religions, economic status, gender, identity, sexual orientation, disability, and zip code. And so in that, we have 6 priorities, of which one is equity and inclusion. So we've been thinking about this for quite a while. And then in 2020, not only did we have the pandemic, but George Floyd's murder, which was a mile from my house, really kind of galvanized a lot of really intense work around a variety of topics related to equity across the country. And at the NAIC, the approach that organization took, so the NAIC is all of the insurance commissioners across the country, was to create a special committee on race and insurance. That committee has several work streams, including one on health. So I co-chair the work stream on health. And that charge is to look at measures to advance equity through lowering the cost of healthcare and promoting access to care and coverage. And then it goes on to say a specific focus on remedies that impact people of color, low income and rural populations, historically marginalized groups, and Alaska Native and Indigenous folks. So we've taken a fairly broad approach through that work, and we've talked about network, we've talked about outreach, and we've talked about benefits. We've heard from carriers and regulators and consumer groups from all across the country. And there are a few things that I think are really important to highlight. The first, and the one that I think is the most important, is that engagement with communities is super, super important in any work you're doing around equity. There are a lot of assumptions that come in, I think, and communities can tell you what they need, and then you can work backward into figuring out the policy levers to, advance goals toward those, towards those needs. So I'll give a quick example from the disability community. One of the presentations we had said, a lot of people come to me saying, oh, you have a disability, you're probably really concerned about seeing specialists. And she said, no, I don't care about specialists. I know who my specialists are. I want really good primary care because that's the nexus of all of my care. And so, really intentionally engaging, I think, is really sort of critical to making sure that that we as regulators or policymakers are doing the right kind of work. The second is that benefits are really good tools to advance equity. We've seen a lot of interesting things, which I'll talk about in a little bit. And each state is different, right? There are a lot of states that have different markets, different populations, and different ideas within their state. So what works in Minnesota may not work in Florida or California or Iowa, even though we're close by. And so I think that looking and having a variety of different tools in our toolbox is something that will be really important, and something that we're going to work toward in that committee over the next year. Our goal is by the end of the year to have a toolbox. So if you're a regulator that says, I want to do something about this, we can say, here are the 5 or 6 things you might want to look at. And that'll allow states to kind of choose the right things for them in their state. So today, I'm not going to steal Mila's thunder. So you'll hear from Mila Kaufman in DC. They've done some really great work. So I'll just lift that up now. Colorado has designed standard plans and a public option, really thinking about equity. New Mexico has looked at some of the ways that their cost sharing structures in the ACA have impacted their Native populations. They have a fairly large Native population, also a lot of people on Medicaid. So when they have their individual market in particular, there's some kind of like interesting, we'll call them dynamics. And so they've looked at ways that they can get people into better coverage by being thoughtful about the choices that they're making, and that to make sure that they can sort of give the best options with the best coverage. So I'll put my Minnesota hat back on. We've implemented an insulin affordability program, and our state Medicaid agency has started to look at equity in their procurement process. That's just started last year, so we'll have results, I think, and then in the coming years. This year, we and the insurance department are pursuing a standardized plan proposal. And the one that I'm probably the most excited about is that we have a proposal to study how we would have no cost, no barrier care, free primary care, or free primary care, depending on how you want to look at it. So we're going to take the lessons that we had from our COVID experience, which was that the state stood up a number of locations where you could get tested or vaccinated. If you had insurance, they charged insurance. If you didn't, you could still get tested or vaccinated. We want to replicate that with basic care. And that one I'm really excited about because I think it's an equity proposal. It's also one that can advance a lot of the goals of adding value and adding prevention into our system. So these are examples. They're not inclusive. There are a lot of other ideas. You'll hear some later. There are other kind of approaches that states can take. And so I think by the end of the year, we're going to have a really good toolkit for state regulators. And I'm really excited about that. I do want to say, these opportunities are not coming without challenges. So in the regulator seat, we sort of are used to saying, okay, there's a yearly look at rates, and it's confined by the AV calculator, and carriers may want to move, but they don't want to move on something until everyone in the market is moving. And so I think that's a challenge, but potentially an opportunity to get all carriers in the same boat and get the market kind of moving in a direction that is advancing equity as much as possible. So, I think I'll close. So much of this is sort of new, and we don't have results from many of the, I think Kristen talked a lot about some of the sort of macro coverage and sort of cost sharing pieces that have been super helpful, where the federal government has sort of come in and supported a marketplace in which states can then add on. There are a lot of states that are thinking about things or have implemented something in the last year. And so over the next couple of years, I think we'll really start to see the fruit of those efforts. I know there are a lot of folks on here. So my sort of suggestion to all of you is to come talk to your regulators and help us to learn how we can do work together that advances equity, that reduces disparities in our markets, and that does it in the slice of the market that we oversee, and in the in the places where we have tools that we can advance equity, because the regulatory market isn't everywhere. So in my mind, the places where we have great collaboration, we're going to be able to go really far, and I'm really excited about a lot of the work that we're doing.
Well, Grace, thank you very much. And you really made very clear how you go about community engagement, that it's an essential element. Really interested to hear about the toolkit you're talking about. Again, you're being quite practical and on the ground about it. You laid out some clear challenges, and you basically laid out an invitation to come work with the regulators. And I guess the door is open for that. And again, your state in particular offers a great model for kind of trying out these different approaches to see what works in practice. And that's good, something that's not only good for your own state, but for sharing across the country. So gosh, we really appreciate that. Thanks very much, Grace. Let's move next to Jonae at CVS Health. Jonae?
Yes, thank you. Excited to share a bit about CVS Health and how we're thinking about advancing health equity. I'll start by saying health equity is actually not something that is new to CVS Health. So in 2002, Aetna, that's one of the core businesses of CVS Health, was actually one of the first health plans to actually start collecting race and ethnicity data, not without a lot of pushback over 20 years ago, but started collecting that race and ethnicity data, and then also started developing actual specific initiatives to be able to address those disparities that, no surprise, the company found. Again, that was over 2 decades ago. I would say that we've also been historically quite proactive, actually, when it comes to investing in and partnering with communities, and in particularly working to address social determinants of health. As many of you are aware, and quite frankly, in my role in the state of Michigan, leading their COVID-19 response, CVS Health was actually a great partner for us in the state when it came to advancing COVID-19 testing, access to vaccines, and not just access in the brick and mortar stores, but also making sure we were getting those tests and vaccines out into communities. And so I would say again that it's not new to CVS Health, but in 2021, the proactive decision was made to really make this a focus of the company and creating this kind of executive position to align efforts across the entire enterprise. So certainly honored to be in this inaugural role for roughly about 18 months. And I would say since then, we've really ignited our efforts and are focusing on embedding health equity into the way we do business. And I think this is a really important point. Health equity is not about a series of programs. I think there's often this kind of, okay, health equity, what are those 1 or 2 programs you're doing? When are those disparity gaps going to be closed next month after you implement the program? The disparities that we see, unfortunately, took centuries, right, to come about. And so it's going to take incremental, but very intentional, specific steps collectively as a healthcare system across all of our different companies, agencies, payers, et cetera, to be able to advance health equity. So it's really about thinking about how you do your work, your policies, your decisions, how you look at your data, which I'll talk about in a moment, and as was already discussed, how you are engaging with communities. So how are we doing that at CVS Health? We've identified actually 3 core pillars of our health equity work that's really foundational in how we think about as a company, supporting our members, supporting our customers and our clients. So that was actually really an important first step for us. And I think that's important for others out there who are thinking about what they can do as a company. Actually align on a strategy, have very specific goals, tactics, and outcomes that you're trying to achieve, and make sure you're really aligning every single part of the company. So that's really, really important, and really the first step that I made in this role. So I'll go through our 3 pillars a bit more. Our first pillar is really around empowering our colleagues. We have over 300,000 people who I have the honor of working with across CVS Health. We're very intentional about our learning and development strategy. So our colleagues really understand not only what our health equity strategy is, not only the definition of health equity, but also why disparities exist, and they actually have the tools, whether they're administrative, whether they're frontline, whether they're working in our insurance plans, they actually have the tools to be able to advance health equity in their daily work. So as part of this, one of the specific tactics we have internally is actually implementation of a health equity business unit impact assessment tool. And this is something we actually have developed internally, where we work with business leaders to talk about key ways that they're engaging with communities, looking at data, training their colleagues, very specific tactics, and we assess how we're doing as a company within specific business units, and then we develop action plans and implement them together, again, embedding health equity into how we just do our work. Our second pillar is really around data. I like to say you measure what you treasure. If you don't understand where there's disparities, you're not going to really be able to address them. And so we are actually working, as I know many companies are as well, but standardizing first, and then increasing our collection of self-reported health equity data around race, ethnicity, so ethnicity with more granularity than the usual 5 boxes that we're all kind of forced to check. And God forbid, if you check more than 5 of those, or you need to check something outside of those boxes. We're also collecting gender identity, sexual orientation, preferred language, and disability status. And so we're already leveraging those analytics. We already are creating those dashboards with that self-reported data, also connecting it to what we understand as far as our members, our customers, and their social needs. And really with those insights, being able to really get very specific and very local about how we are actually addressing the disparities that we're finding, and implementing high quality evidence-based services and eliminating barriers to care. And then finally, and this was really important as well, we are actually as a company focusing on specific actions and specific actually topic areas when it comes to health equity. So yes, as a company, we are embedding it in how we are making decisions, how we're looking at data, but we also made a decision as a company to really focus on key drivers of health disparities when it comes to topic areas. So heart health, mental health, and women's health are places where we are aligning our company efforts, where we're looking at our quality metrics, where we may have disparities, and then very intentionally developing tactics and strategies to either expand or newly implement strategies to be able to address those particular topic areas and disparities that we're finding. And all of this is done in a very evidence-based, data-informed way. And so what does success look like? This question often comes up. As I said, the disparities that we see took centuries to develop. They're across many systems, not just the healthcare system. But success, I would say, is when we actually see health equity happen, and specifically when we can actually measure those health disparity gaps close. When we use our data, we may see that there are disparities, racial disparities in high blood pressure control, as an example. When we actually do the work well, we expand access to care, we understand why those disparities exist, and we implement those programs, we should actually see those gaps close. And not only see those gaps close, we should actually see all health outcomes for everybody improve. And that's an important point as well. Health equity is certainly not a zero-sum game. It's not a competition. It's not about taking away from one particular group to give to another so that one group gets less healthy. It's really about raising all boats and making sure there's no gaps, and we get everyone what they actually need. So that's how we're thinking about health disparities and health equity as a company. Again, really just embedding it in the way we do our business. And so with that, I will turn it back over to you, Cliff.
Well, thank you, Jonee. You certainly shared with us not only your executive hat, but your doctor hat. You just kind of went through all this. Really appreciate it. And I noticed that you did talk about how even starting with Aetna, started collecting data on race and ethnicity. So we've got a good basis there. You say that this issue is something that you embed in how we do business. You talked about 3 pillars, empowering your colleagues, data on disparities, and then specific activities or topics that are looking at disparity drivers. So you've kind of aligned your strategies and tactics that way. And you're going to use those deep data resources to monitor that, see if you can close the gaps and improve outcomes. So that's a pretty good package right there, I must say. Thank you very much. We have a bunch of questions here, and I just want to start out with the first one I mentioned earlier, back to Kristen. Kristen, we've had a couple of questions about who is still uninsured and what's that percentage. That's part one. Part two is a little update on Medicaid and where Medicaid and the market exchange might have a chasm, gap between them. So uninsured, where's Medicaid going, and is it going to be in jeopardy for some people?
Sure, great. So thanks for those questions. And yeah, so first of all, the uninsured rate is now at 8%, which is the lowest that it is, ever been recorded to be. That does still leave millions of folks without health insurance. And some of the populations that are most likely to be uninsured are first people who live in Medicaid non-expansion states and have income below the poverty level. So those people are eligible for any form of subsidized health insurance, as this group knows, because of their state's refusal to expand Medicaid. There are now 11 states. We've checked 3 states off the list since President Biden took office. There are 11 states that have not expanded, hoping to cut that down to 10 here in the next couple of weeks when North Carolina is poised to expand Medicaid, but making progress across the board. But in those 10 states, there's a group of folks that have no access to health insurance, and as I think this group knows, and certainly relevant to today's topic, that group is disproportionately low-income people of color in the South, a population which experiences a number of vulnerabilities across a range of issues that we talk of, which all of which are closely can be linked to their state's failure to expand Medicaid. There are other populations of people who simply, they do have access to an insurance affordability program, either Medicaid or subsidized coverage in the exchange, but they have not focused on the ability to get coverage, or not necessarily aware, think coverage is going to be more expensive than it is, or are aware of the prices and still think coverage is too expensive. So there's absolutely more work to do to reach those folks, and this administration is committed to doing everything we can to reach people and help them understand their options. I suspect the question is also getting at sort of what we are going to see when Medicaid resumes eligibility determination, particularly in those states that have not expanded Medicaid. So there is a population of people who became eligible for Medicaid at some point in the last few years, and now may have incomes that render them no longer eligible for Medicaid, or their eligibility category has changed. And so in states like Texas and Florida that have refused to expand, there are unfortunately going to be people who lose access to health insurance, and millions more who don't have access at all today. And that's a critical population. Let me just say one more sentence on this, which is, we're going to keep working to expand Medicaid in those remaining 10 or 11 states. But the president has also made clear that Congress can act here, and that Congress can close the coverage gap once and for all in those states, and that is he has supported for years and continues to call on Congress to do.
Quite a bit there. Thanks very much, Kristen. We've got more questions we can handle, a couple more coming up. This one I want to direct primarily to Jonay, but others can chime in. Jonay, you talked about kind of the deep health data on race and ethnicity and trying to close disparities. Can you get to a next layer and talk about, if at all, if you can, about the kinds of metrics you're using, or exactly what you're really analyzing, other than saying that we're looking at a lot of data? Any particular things you might be tracking, for example?
Absolutely. So as any health plan would have, we have quality metrics, obviously, right? So we're looking at our HEDIS measures, right? Our STARS measures, looking at how we are collecting self-reported, some imputed, but also self-reported race and ethnicity data, and literally working with our data teams to understand where there are disparity gaps in those particular outcomes. So I can't share more about the specific ones at this time, but certainly when you look at your quality metrics, we're looking at race and ethnicity, connecting that particularly for our commercial members actually with their social risk scores. And how they may be struggling with social needs in the community, and actually tailoring very local specific interventions to address those social needs and to close those disparity gaps.
So in a certain way, then you're tallying race and ethnicity data, but somehow you're linking it or comparing it to quality metrics and other metrics that might say that they're marking disparities there, correct? Some kind of data linkage, right?
Absolutely. We can connect within our systems, the information that we have. We have, whether it's imputed or self-reported race ethnicity data, hoping to expand that beyond sexual orientation, disability status, et cetera. But we do have self-reported data, and we actually have outcomes on a population health basis for those particular members as well. So you can actually see disparities among your members.
And then one kind of follow-up to that, once you see those disparities, Joné, from your position, to whom do you feed that back? In other words, oh, we're finding disparities here. Who hears that message or the feedback on that?
Oh, absolutely. I mean, again, this is part of how we're working within our health plan internal conversations, right? So it's not just me and my health equity team, right? We're embedded with the Medicaid teams, with the Medicare teams, we're talking to local health plans. They actually see their data at a local level and can say, oh, in this particular geography, this particular group has a disparity in outcomes. What are we doing? Are we going to, for example, within our health plan, embed community health workers or social workers? Are we finding challenges with access to transportation? So we need to think about that differently in this particular geography. So it's not dashboards, to your point, for the sake of having a pretty dashboard, it's actually insights so that you can then develop the actual initiatives or expand the initiatives so that you can actually see improved outcomes. I mean, one example we actually have is in our Medicare program, our Medicare multicultural initiative. We actually, a couple of years ago, for Black and Hispanic Medicare members, identified disparities in health outcomes and high blood pressure and diabetes. And we actually very intentionally worked in those in two particular geographies to actually work with providers, to engage the community, as was already talked about here, understand what those kind of disparities were. We did a lot of kind of outreach, patient education. We were actually able to see those disparity gaps close. So it's, again, leveraging the data, but then you have to do something. Having nice dashboards for the sake of it is insufficient.
Hear you. Very good. Helpful.
Cliff, if I might
Grace.
add in, I think we heard a couple of presentations through our conversations. I know that there, I think it's the Blue Cross plan in Massachusetts is using a similar approach of self-reporting data from members. They're giving dashboards to providers directly, and they're looking at ways that they can embed equity in their payment models. But now they're just trying to figure out, okay, if we give a dashboard, what does that mean? And I want to underscore Joné's point that if you can measure something, but if you aren't doing something about it, then that's sort of like you have to do something with it. One of the things our Medicaid agency is doing, they contracted with a lot of community organizations through COVID to bring our disparity in COVID vaccinations down so that we increase the number of Black and Brown Minnesotans that were getting vaccinated. They were really successful in doing that. They're going to contract with the same organizations to do outreach for the Medicaid unwind to make sure that, when eligibility is redetermined, that we're not losing ground on our coverage. We still have coverage gaps, and we don't want to lose ground on those.
Got it. Thank you very much. Mental health. Can anyone of you address how you're looking at mental health insofar as advancing health equity? I know we don't have a lot of time, but any sort of volunteers? Joné, are you nodding your head? Yes. Mental health.
I am.
Okay.
Don't want to take up all the airtime here, but absolutely, mental health is one of the key focus areas for our health equity strategy. Understanding, before the pandemic, 1 in 10 Americans, had symptoms symptoms of anxiety and depression up to 4 in 10 a couple years into the pandemic. So we absolutely are expanding access to mental health services and screenings, making sure they're not just screened, but we actually have that follow-up care. We're connecting with our primary care providers as well to make sure they are able to screen and connect people to the appropriate services, knowing that a lot of people with mental health needs are not going to just go to a psychiatrist or psychologist. They're showing up to primary care. So providing those screenings and services, including in our mini clinics, is really important. So absolutely, it's a focus for us at CVS Health.
Thank you. Grace and/or Kristen on mental health.
Yeah, I will just add, I mean, echo, everything Jonae highlighted about the problem. We are using levers across the federal government to tackle this problem. There's no silver bullet, but we know we need to break down cost barriers to care. We need to be supporting, providing care in more convenient locations to people, whether it's primary care or schools or other sort of non-healthcare settings. We need to be supporting the pipeline of mental health professionals and can use federal resources to fund more training for mental health professionals. And we need to be promoting messages of resilience and well-being, and are really thinking about how we do that across our program.
Good, thank you. Here's a business question basically, and it's about return on investment. And I'm going to paraphrase. So this is all well and good. Nobody's against, we don't think, narrowing disparities. But for your programs, how do you say that this is really worth it? Devoting effort to data collection and programmatic initiatives and so forth, even from a business reason, makes bottom line sense. Any takers on that question? Where's the ROI?
I can chime in. I'm not
Okay,
waiting
Jonae,
for others.
go ahead.
But I think you bring up an important point. But health equity is not just a moral imperative. I would say it's a business imperative. A study by Deloitte came out, I think it was last year, that said that it's going to cost the U.S. healthcare system $1 trillion by 2040, just health disparities, racial health disparities. And again, going back to my earlier point, health equity is not just about, we're talking about specific health outcomes. We're talking about a group of people who have worse health outcomes, using the emergency department where I work more than they should, having chronic disease challenges. When you actually improve the health of people, you will actually save the healthcare system money. I'll also add the demographics of our country, as everyone knows, is changing. You've got more than 50% of the workforce that will be people of color in the next couple of decades. So when you think about it as a business, if you've got people who work for you, who are out, who are struggling with chronic conditions, have decreased productivity, that's important as well. But I also think we have to level set again. These disparities took centuries to develop. There is not a 3-month turnkey program that you can implement and all of a sudden say 6 months from now we changed all, we eliminated health inequities and we've got this, $1 trillion ROI. I think that's unrealistic, and quite frankly, I think it's a little bit unfair. But I do think there is a business case for health equity.
Good, thank you very much. Grace, did you have a comment you're about to make on that one?
Yeah, I think, a lot of the systems that we have, particularly in the regulatory space, are year over year. And I think that can really hamper progress on equity because we're looking at actuarial analyses year over year. We're looking at, benefits year over year. And I think I just want to underscore Jonae's points about having healthy, productive members of our states should be, from a state perspective, is absolutely the thing that should be a goal, and that it will take time to bear out. But it's also, there are ways that you can look at the data that will tell you not to do something. And I think in addition to the moral imperative to do something, there is a longer term value. And so you have to think broadly about what your return on investment is. In some cases, it may be healthy citizens, which is absolutely something we should be looking for.
That's not a bad return, you're right. In just a few minutes left, and I'll go to Kristen on this, and maybe Jonae would weigh in as well, and I'm paraphrasing here. When government makes a move, like for example, putting a cap on insulin, we've seen a little bit of response from industry as well. What can you say about the crossover effects of state or federal government actions to reduce disparities and response from industry? Kristen, do you have a take on that? Maybe Jonay could weigh in as well briefly.
Sure. So I think you see this across the board in this work that we are talking about. You highlight the change from one of the major insulin manufacturers around their pricing in response to both federal government pressure as well as changes in market dynamics based on recent legislation. But we, which I think was a particularly high profile example of this phenomenon, but as federal and state payers, we have enormous influence over how the market rewards the delivery of healthcare. The fundamental structure of Medicare payment is repeated across the healthcare system, for good or for ill. And so, we think as a primary payer for healthcare, I think we are cognizant every day that the incremental changes that we make to the types of care we reward or the structures that we place or the quality measures that we use, flow very naturally through the healthcare system. And so we can make small changes and drive bigger impacts.
Excellent, thank you. There's plenty to watch there, including every day this week. Jonay, a closing view on that industry government dynamic there and mutual responsiveness, Jonay?
Yeah, I think it's really important what the federal government does. I mean, my background, most of the past decade, I was in government and I saw a great opportunity to work in industry to advance health equity. So certainly things like, the feds are already looking at expanding collection of data, advancing social determinants of health and screening for social needs for providers. So I think all of that's really important. And certainly we pay close attention to it in the industry.
That's great. Thank you very much. A lot of stuff going on, like I said, every day this week, including today, a lot of action here. Thank you, Keynote panel on accelerating equity. You have set this up beautifully. And I think we're all very fortunate that you have brought three distinct perspectives, although each of you in your distinct perspectives wore multiple hats. Kristen, multiple hats, Grace, multiple hats, Jonay, multiple hats as well. So we really got kind of almost two panels for one here. So thanks to Kristen Linke-Young, Dr. Jonay Calhoun, and Grace Arnold. Great way to get it started. You've set the tone, and we're going to move on to our next panel.